you for joining us today again for our monthly webinar series. My name is Leslie and I'm going to be the moderator today. A few quick ground rules. As usual, we're going to be keeping the phone lines on mute, but we encourage you to ask questions. If you have any questions, please use the questions box. If we don't get to your question, we will answer your question at the end of the presentation in email or in writing, and then we'll also be answering all questions verbally at the end of the presentation. Our presenter today is Andy Petrovich, MCEDA's in-house lead security risk analyst. Andy will be talking to us about security risk analysis measure as it relates to meaningful use, the documentation that follows, and the full requirements. A little bit of background for those of you who don't know MCEDA. We are the Michigan Center for Effective IT Adoption, a program that is led by the nonprofit Al-Tarum Institute. We were chosen as Michigan's official regional extension center in 2009 by the Office of the National Coordinator, one of only 62 in the country. Our program is primarily funded through the Centers for Medicare and Medicaid Services and the Michigan Department of Community Health. We're here to help accelerate meaningful use in health IT in Michigan. To date, MCEDA has helped over 5,000 providers in the state of Michigan with EHR adoption and implementation. In fact, a third of all Michigan physicians paid for meaningful use stage 1 are MCEDA clients. We offer a variety of services, both subsidized and fee-for-service. Our biggest service that we offer is the meaningful use support for both the Medicaid and Medicare EHR incentive programs. We do security risk assessments as part of the EHR incentive program, but also as a fee-for-service on the side. We have targeted process optimization, which is a hybrid of lean principles and best practice applications. And then we also have attestation and audit preparation help as another fee-for-service on the side. With that, I'm going to turn it over to Andy to get started on the SRA information.
All right. Thank you, Leslie. Good afternoon, everyone, and thank you for tuning in. There is a lot of information and some misinformation about security risk assessments and the HIPAA security rule out there on the internet and beyond. So it's our goal to help you sort through it all by giving an overview of security risk assessment requirements and what steps need to be taken for an SRA, security risk assessment. There's a lot more information than we can cover in an hour, so we recommend that you seek as much knowledge as you can, and we'll point you in the direction of some good sources at the end of the presentation. Risk is something that we all have a sense of. We know that there are risks out there, but we don't want them to stop us from getting out into the world, putting resources to good use. So the question is, how do we ensure security? Well, it's a complicated process. But the first step is awareness. You can't account for risks until you're aware of them. Once you're aware of the risks, how you deal with them is a business or a personal decision. But again, that first step has to be awareness. And the purpose of a security risk assessment is to create awareness. The purpose of this webinar is also to raise awareness. So let's start with the big picture. The HIPAA security rule is one part of a much larger piece of legislation. HIPAA was made law in 2003. I'm sorry, the current version of HIPAA was made law in 2003 with an effective date of 2005, which means that SRAs have been required since 2005. But many providers are just now becoming aware of the SRA requirements and the security rule as a whole because of meaningful use. As many of you know, meaningful use stages 1 and 2 require an SRA be completed as a core measure, and we expect the same for stage 3. The SRA is one part, the first part of a larger security management process required by HIPAA. Risk assessment requires covered entities to conduct an accurate and thorough assessment of the potential risks and vulnerabilities to the confidentiality, integrity, and availability of EPHI, or electronic protected health information, held by the covered entity. Covered entity being defined as, in this context, any provider. Oh, I'm sorry. jumped the gun here. Risk management requires covered entities to implement security measures sufficient to reduce risks and vulnerabilities to a reasonable and appropriate level. Covered entities must apply appropriate sanctions against workforce members who fail to comply with the security policies and procedures of the covered entity, and further, implement procedures to regularly review records of information system activity, such as audit logs, access reports, and keeping track of security incidents. SRA documentation is always requested during a breach investigation. So make sure you document everything you're doing. You're doing the work, you should take credit for it. As many of you know, an SRA, as just described, is also a requirement to attest to meaningful use. Conducting an SRA for meaningful use is a great first step in a risk management program. However, while meaningful use requires an SRA be completed prior to attestation, the HIPAA security rule is broader, and in order to achieve compliance, you will need to address and meet all of its requirements. While the SRA is its own measure, security impacts patient-family engagement and other measures. For example, patients who are confident in a practice's information security could be more likely to use a patient portal, which is another requirement for meaningful use. While the SRA requirement is a very small piece of legislation, it has raised a number of questions. To help clarify what an SRA needs to be, the Department of Health and Human Services Office for Civil Rights, or OCR, has issued guidance on risk assessment. Scope must include all EPHI, again, electronic protected health information in an organization. So it's not limited to just your EHR. Any and all devices which transmit, store, or process EPHI must be included, as well as the policies and procedures governing the use of those devices, the personnel who use the devices, and the physical location those devices are kept in. Data collection and methods must be documented, so you make sure you do that as well. Then you also have to identify and document anticipated threats and vulnerabilities. Threats being defined as potential external events that can compromise the confidentiality, integrity, or availability of your EPHI, while the vulnerabilities are internal factors that those threats could act upon to compromise your EPHI. You need to assess your current security measures in place, the things you have to try to prevent threats from acting on those vulnerabilities. You need to establish a likelihood of threat occurrence. This will vary from business setting to business setting. You need to establish the potential impacts of threat occurrence. So that is to say, if the threat were to act on and exploit a vulnerability, how would it affect your medical practice? How would it affect the EPHI in your practice and your overall viability of the business? Then from that, you would determine a level of risk. And risk specifically would be combining impacts and likelihood of those threats, exploiting a vulnerability, leading to a change in EPHI. Then you need to document your completed risk analysis and have periodic reviews and updates. So this is all kind of high level, and that is how HIPAA is written. There's really no one way to do an SRA. But every method must meet these objectives, and the documentation that you provide should reflect that, so we recommend using this language as much as you can. So now we know a little bit about the rules. So why are all these regulations in place? Well, it's because bad things truly happen to patients' personal information of a data breach to all parties that can affect a positive outcome. That is to say, it extends the chain of accountability. And here for your viewing pleasure are the top 10 most common adverse outcomes or bad things that happen related to privacy and security of patient information. Number 10, having incomplete HIPAA authorization forms. Before releasing any information to outside parties, it is imperative that you double and triple check to ensure that authorizations are completed from top to bottom. The form should clearly list the patient's name, the party or parties to whom information may be released, which specific aspects of their medical records can be released, and the date through which the authorization is valid. Number 9, exclusion of a right to revoke clause. Your patients have the right to revoke their HIPAA authorizations, and this right should clearly be stated on the HIPAA form, lest the authorization become invalid. Number 8, failure to establish contracts with business associates. The omnibus final rule has extended the umbrella under which covered entities, business associates, may fall. Liability is officially extended through the omnibus rule with or without the business associate agreements, but it also requires that you put these business associate agreements in place. Should your business employ any outside party to handle, process, or transmit patient protected health information, you must establish a contract with that agency. In the contract, your business associates must agree to comply with HIPAA regulations, including a security risk assessment, I might add. Number 7, release of information after the authorization period has expired. You need to insist that your staff take the time to verify the expiration dates on HIPAA authorizations each time that a release of information request comes through. Although everything else may appear to be in order, if the request for information comes in after the expiration date, a new authorization form will need to be completed. Number 6, errors in paper file storage and disposal. Some of the most common HIPAA violations occur as a result of human error. It's all too easy for an administrator to incorrectly file patients' records or mistakenly discard a private document without shredding it. Breaches like these can be avoided by switching to an electronic filing database. Number 5, failure to release patient information in a timely manner. Number 1 privacy rule violation, another edition of the Omnibus Final Rule, is the requirement of medical facilities to release electronic copies of medical records to patients upon request. Should your facility be unable to respond to the request in a timely manner, you could be fined. Computer hacking comes in at number 4. An example, in 2012, the Utah Department of Health confirmed that a server with a PHI of more than 780,000 patients had been hacked into, leaking addresses, birth dates, social security numbers, diagnosis codes, and so on. Encryption, firewalls, and other security measures are imperative to protecting electronic information. Number 3 is the loss of backup disks or portable drives. An Atlanta-based hospital system misplaced 10 backup disks storing PHI of over 315,000 patients. Accountability logs and federal records should be kept when dealing with backup disks, and any thumb drives should be password protected and encrypted. Number 2, employees inappropriately accessing, using, or transmitting PHI. Some of the most common HIPAA violations involve healthcare employees accessing files inappropriately, either out of curiosity or maliciously. Using clearance levels and user ID codes for accessing PHI will discourage this behavior. All right, drum roll please. The number 1 most common violation of HIPAA privacy and security is storing unencrypted patient information on laptops. The largest volume of HIPAA violations occur as a result of storing ePHI on unsecured laptops. If ePHI must be accessed remotely, consider utilizing a cloud storage database. Remember that your cloud providers need to sign business associate agreements, and you need to consider their security posture as well. You want to check their reputation. Further, information on any device should be encrypted at this point in the game, and there are many options out there that are relatively easy to implement. Notice how many of these can be controlled by an organization. Only number 4 is explicitly due to outsider activity. So your own awareness of your security posture can help to mitigate all of these factors, almost all. So conversations about information security usually revolve around compliance, and rightly so. You want to be on the right side of the law, and the laws are they're quite broad, they're complicated, there's a lot of information there to be aware of. But the regulations are in place for a reason, so let's take some time to discuss information security and its broader implications, starting with patient safety. If your credit card is stolen or fraudulently used, your bank can often replenish lost funds within a few hours. Stolen identity information, on the other hand, can affect patients' reputations, credit scores, even taxes. Hundreds of fraudulent tax returns have been filed based on lost information this year alone. As you can see, millions of people are affected every year by loss of personal information, and the costs can be substantial. And it should be noted, something like reputation is much harder to get back, if not impossible, once it's been compromised. With all the news of cybersecurity and identity theft, It's no wonder the public has concerns about the security of their information. 81% of patients are concerned about privacy and security of EHR, and 60% of patients believe that EHR use will increase loss of information, according to recent surveys. In healthcare, one service we offer is giving patients peace of mind. Patients are uneasy about EHR security. You can win their trust by assuring them of your strong security measures, demonstrating how seriously you take their privacy and the security of their information. Another thing to consider is that breaches are made public on the internet. The OCR has a wall of shame. There are real-world examples of hospitals using breach information against their competitors in marketing campaigns, and certainly you don't want to have your practice and your name posted on the internet on the wall of shame or in a news article describing a breach of information. Health information breaches have been increasing over the years, and 2013, last year, was no exception, to the tune of 138% increase from the year prior, 2012. The increased adoption of EHRs has created greater access to patient information. And while ease of access can be beneficial in many ways, it also creates opportunities for it to be exploited. Over the last 5 years, the number of data breaches reported by the healthcare sector has grown at such a rapid rate that it now surpasses the retail industry as the leading sector within the United States. In 2009, healthcare had only 14% of all data breaches, while retail had 41%. In 2013, the number of data breaches within healthcare has increased to 43% of all reported breaches, surpassing the retail sector at 34%. This growth is despite the increased awareness of security risk assessments and the HIPAA security rule. EHR adoption and the spread of digital health information have been sped up by legislation such as Meaningful Use, the Affordable Care Act, as well as accountable care organizations and health exchanges. We've been talking a lot about risk, but if we're going to assess it, we need to define it. The following is a paraphrase of the National Institute for Standards and Technology, or NIST, or NIST, their definition of risk. Risk is the potential likelihood of a negative outcome or impact toward an asset due to a vulnerability being exploited by a threat that would reduce the value of the asset to the organization. Risk exists when you have a valuable asset that contains some vulnerability, and a threat exists to potentially exploit the vulnerability and diminish some or all of that asset's value. That potential is what we call risk. Let's say you have a laptop with some ePHI stored on it. Its portability, while useful, presents a vulnerability as well, in that it could be more easily misplaced or taken. A person entrusted to the laptop may leave it sitting out at a coffee shop while they step away for a minute, and when they come back, it's gone. That's one example. Every system, every asset has some kind of vulnerability. We need to be aware of vulnerabilities and come up with a way to protect the asset while still being able to meaningfully use it. Consider gold in a vault. If it were completely sealed off, there would be no way to access it, and we would not be able to get the value out of it. So we create access by installing a door, but that door creates a vulnerability as well. Controls are all about making the figurative door as difficult as possible to get through while allowing us to get the value out of the asset. It's a process of authentication, a barrier you can only get through if you're supposed to. Depending on the value of the assets and the need for timely access, controls vary in flexibility. For example, it takes fewer authentications to get money from an ATM than it does to draw out of a trust fund. Similarly, a database will most likely have stronger security than an email server. Going back to the vault analogy, not all the money is kept in it all the time. Assets likely to be exchanged frequently are kept up front with lighter security measures in place. So now let's talk about threats. Here's a question to ponder. Do the majority of breaches originate from an internal or external source? Ponder amongst yourselves, but I will give you a hint. Think back to that top 10 list. All right, well, the answer is internal. A very large majority are internal. Lack of awareness, lack of training, and sometimes malicious or disgruntled employees are the common root cause of these breaches. Also, something to consider, especially in light of business associates being included in the chain of liability for a HIPAA breach, is the overlap between internal and external sources. Think about Edward Snowden. Do we consider him an insider or an outsider? Well, he was a contractor, so technically he was an outsider. However, he had insider knowledge and access. Something to think about when you're choosing and defining the relationships with your business associates, contractors, and other vendors. When you're contracting with them, you're letting them in to your organization. It's useful to think about what exactly is being protected and what do we stand to lose. The security rule requires that we protect the confidentiality, integrity, and availability of EPHI. The variables determine the value of EPHI. When one or more of these variables are compromised, the value is reduced. Consider confidentiality, which means basically that you can't get to that information unless you're supposed to. The information is kept private and used appropriately. When this is compromised, the very identity of the patient in front of you could be put in question among other potential harms. Integrity means the EPHI is accurate, complete, and up to date. If a patient's chart reads, do not resuscitate, or no allergies to medicine, you need to be able to trust that the statements are accurate. And finally, availability means that EPHI can be accessed when needed. If you can't get to the information to read it, use it, or modify it when needed, your ability to administer quality care is impeded. So, how do you protect confidentiality, integrity, and availability? Well, there are many, many ways. Every practice is really a unique setting, so there's no one-size-fits-all explanation. This table unpacks the categories and lists a few examples. Broadly speaking, physical safeguards pertain to the facility and immediate location of your practice, such as having locks on the doors, the location of computer hardware inside the office, and the structure itself. For example, if you have a server on site, is the room that it's in also locked within the practice? Are the walls around the server of an enhanced fire rating relative to the rest of the practice facility in the event of a fire, to make sure that it is less likely to be affected by damage from a fire? Administrative safeguards cover policies, procedures, job descriptions, and actions taken. So not only the policies themselves, but also how those policies are implemented in the real world. And technical safeguards pertain to software and system configuration. While an SRA is often thought of as a primarily technical exercise, these aspects are truly a minority of what an SRA must examine, although they are very important. And here's the rub. Even if you are compliant, that doesn't mean you can't suffer a breach. Any audit prep that gives you a stamp of compliance is at best a snapshot of your compliance status at a single point in time. There are really no guarantees. And audits are subjective, with variation in what different individual auditors might prioritize. You need to focus on critical assets and protecting your EPHI. Your SRA will help you prioritize risks, but it's up to you to take security and risk seriously. SRA results should become a routine part of operations. Formally designating a security officer in the practice and involving them early on in any major decision-making processes is a great and required step in having your risk mitigation and risk management program firmly in place. Make security part of your organization's cultural awareness. Everything needs to be taken into account, but you can't protect everything totally. There's no such thing as absolute security. So maintaining awareness through consistent consideration of security is your best bet to keeping your patient's EPHI safe. Speaking of awareness, the Office of Civil Rights is starting a random pilot program for covered entities and business associates in 2014. They had conducted a pilot audit program from 2012 to 2013, and presently we'll just outline the most significant results from those security rule audits. The number one was a lack of or incomplete security risk assessment and a lack of awareness of security rule requirements. Something to be aware of, but will affect most likely a small population of covered entities. Initially, the number given was that there would be about 350 providers audited. However, there have been some changes to that. Just earlier this month, the Office of Civil Rights announced some updates to their plans for the HIPAA audit program. First, the timeline has been extended with no specific dates provided as to when the audits will begin or end. The plan is also to increase the number of on-site audits while decreasing the remote or off-site audits. No specific numbers have been provided on this and how much one will increase while the other reduce. The reason being for increasing the on-site audits is that for a remote audit, the Office of Civil Rights auditors, they're basically able to check and see if you have the required security policies and procedures in place, and to check your documentation to demonstrate that you're following any checking of activity logs. For example, those things that can be documented. But for on-site audits, they will be checking to make sure that you are following the policies that you have in place. That is, if you have a policy in place but are not following it or cannot demonstrate reasonably that you are following it, then you are at risk not only for breaches of patient information due to non-compliance with your own policies, but also for enforcement action from OCR. The OCR emphasizes time and again the primary importance of conducting a risk assessment. As I just stated, it was the number one finding, the number one adverse finding in the audit, the pilot audit program. So let's review the exact steps of an SRA process following NIST guidelines. So step one, identify and classify assets. And again, this relates to the scope of your risk assessment. Assets include all of the IT equipment on site that stores, processes, or transmits EPHI. So again, it's not just your EHR, but any computers, copy machines, printers, faxes, or portable media that might be used. Step two is to identify and classify threats and vulnerabilities. Again, threats being external and vulnerabilities being internal potential sources of a negative outcome. Step three is to assess your current controls. You want to take a look at what you have in place to prevent those threats or vulnerabilities from resulting in a negative outcome. For example, if you have a server on site, a safeguard that is in place automatically is that there will be an administrative password for that server, but it is at times overlooked that that password needs to be changed. An out-of-the-box configuration for that password would likely be password or admin. And there have been breaches with organizations that did not change that default password. So while they had a control in place, the password for administrative access to their server, by not changing it from the out-of-the-box or default configuration, they had a control in place that was not particularly useful, just as one example. Step four is you need to determine the likelihood of a threat occurrence. So when you're looking at all your assets, considering threats and vulnerabilities, and assessing those controls, you also need to think about what are the odds that a threat will act on that vulnerability. Step five, you need to analyze the impact to your organization. Impact defined as a negative outcome to your organization's confidentiality, integrity, or availability of EPHI. So when you're considering impact, a threat or vulnerability may act on just the confidentiality, just the availability, or just the impact, or some combination thereof. And so you can rate the relative impact of different adverse events accordingly. One example of how to do it. Step six, you determine the level of risk from all those previous considerations. Risk, again, is a combination of likelihood and impact of an asset's vulnerability being exploited by a potential threat, resulting in a reduction in the value of that asset. In this case, again, your patient's information. Step 7 is to implement security controls, or if you have controls in place but your risk assessment deems them to be inadequate, you can improve those security controls that are already in place. And part of your risk assessment documentation should outline what the changes you've made to those controls. That is part of Step 8, your ongoing risk management program and recurring SRA review. Risk assessment is not just a one-time thing. You need to update it periodically, and it needs to be part of your ongoing business operations. And as with any compliance-themed discussion, all steps require extensive documentation. A general rule of thumb when dealing with auditors or preparing to deal with auditors, if it's not documented, it didn't happen. So everything that you do that you want to take credit for, make sure you have it documented one way or another. MCEDA's SRA service and toolkit is based on NIST guidelines, mainly those for security risk assessments and security rule implementation. The MCEDA Security Risk Assessment Toolkit follows NIST guidance, in particular special publications 800-30 and 800-66. These are publicly available, so feel free to avail yourself of this information for conducting your own risk assessments if you so desire. MCEDA, we do work on site with practice leaders, and we guide you through every step of the SRA process. We deliver the analysis results and also a recommended plan of action to improve compliance, in addition to a resources toolkit, for example, some policy and procedure templates, some educational materials, all of which can help you with your risk management program on an ongoing basis. Here's a screenshot of our assessment tool. The tool examines all requirements of the security rule for your practice. It uses determinations of likelihood and impact to calculate a risk level for each asset vulnerability that could be identified. Another screenshot, this time of one of our policy samples. These are provided to clients to assist in the ongoing risk management program. And while these samples cover all the bases in a general sense, every practice is truly unique, and every policy should be thoughtfully considered and modified as needed to make sure it is something that's realistic and attainable for your practice. And these are designed with that in mind. You're able to make modifications to make sure that the policy is something that will be followed at your practice. Again, the idea being, if your policy isn't being followed, it's not truly an asset to your organization, and you are still at risk. So we're getting about to the time to wrap up, and if you're attesting to meaningful use, you need to make sure that your SRA is complete before attestation. In most cases, the risk assessment needs to be conducted during the reporting period. Generally speaking, only providers in the first year of meaningful use can perform an SRA before the start of the reporting period per the original final rule. However, CMS has recently announced special exceptions for those who are using the 2014 CEHRT flexibility rules. In order for you to be able to attest to a previous reporting period in the year 2014, as long as you conduct your risk assessment prior to attesting, then you will have met the requirement. However, that only applies to those practices exercising the CEHRT flexibility rule changes, and it's only for 2014 unless otherwise notified. Additionally, CMS requires an SRA be performed every year of attestation. Subsequent security risk assessments should build upon the previous risk assessment. So the second or third time around, it shouldn't be as work-intensive as the first. That said, it's also an opportunity to drill down more specifically into some vulnerabilities that might have been identified before, or some security controls that were deemed to be acceptable in a previous year. It's also important to consider those because the environment and the circumstances may change. So anytime you have a major physical renovation to your practice location, if you change sites, if you're making an extensive upgrade to your hardware or software, considering the risk of making those changes, it should be an ongoing process, and those changes should also be taken into consideration on subsequent risk assessments. At MCEDA, we're frequently asked if all deficiencies uncovered by an SRA need to be corrected before attesting to meaningful use, and the answer is no. You will be expected to make progress on improving any deficiencies, though, so your subsequent SRAs should not continue to uncover the same issues as the first, and it's certainly possible for meaningful use auditors to look at more than 1 year of documentation for meaningful use attestation. And if you've already done an SRA for 2014 prior to the beginning of your reporting period, we do advise you to do an SRA during your reporting period for meaningful use attestation purposes. Another common question is how frequently an SRA needs to be performed. Your risk management program should be continuous, and risk assessments should be performed. We recommend at least annually. However, as I referred to before, if your organization or the surrounding environment that your practice is in experience a major change, you should make an update to your SRA to reflect those changes. Frequency depends on circumstances. For example, you may have heard about a recent Internet Explorer security bug. Microsoft has released a patch for the bug, but if you're still running Windows XP, and in fact some practices are still running Windows XP, you will not be able to get those security patches. And Windows XP has been no longer supported by Microsoft since April of this year. So if any of you out there are using Windows XP as an operating system for your computers, we strongly encourage you to update your software. Similarly, if you make a significant change or update your EHR version, not every single update necessarily, but for example, to a 2014 certified EHR product as opposed to the 2011 requirements, you should also account for those changes in your SRA because there are some substantial changes that occur from time to time. So in conclusion, security risk assessments are required for compliance with HIPAA and meaningful use. Risk and regulatory oversight are increasing as the world continues to become increasingly interconnected in the information and digital age. And practices are expected to take compliance seriously and put forth a good faith effort. And you should also be able to demonstrate this with documented policies and procedures, documented risk management program, and documented risk assessments. What's required ultimately is hard work, diligence, and integrity in following these processes. An SRA is the first step of a continuous, comprehensive risk management program that will benefit your patients and your practice. And never forget that. It's not just about compliance. You are protecting your patient's information, and you're also protecting your practice from potential liability. So here's some quality resources for further reading. In the PDF file version of these slides, which will be disseminated, these are hyperlinks which you can click on to take you directly to that listed resource. And if any of these links, for whatever reason, don't work, feel free to just copy and paste it in the Google search bar. Pay attention to the domain that you're using. If you're doing that, make sure that it's a hhs.gov source or CMS or ONC as appropriate. And at this time, we'd like to open the floor for any questions you might have. Thank you for listening.
All right, and we had a few questions come in during the broadcast. The first one that came in said, I heard that because I did an SRA last year that I don't need to do another one this year. Is that true?
Well, yeah, the basic answer there is no. And I've referred to this a little bit, but let me unpack it a little more then. So for example, if you're in your first year of meaningful use, technically a previous risk assessment, it could apply to this year based on what we just discussed with some of the flex rules there and what the final rule states. However, if in the course of that year you upgraded to 2014 certified technology, implemented a patient portal, made any significant changes to your practice, and you absolutely should update your risk assessment. And again, to attest to meaningful use, each year you should be doing an SRA. Now again, that doesn't mean that you necessarily have to repeat the entire process that you might have done for the first year. It should build upon previous year's SRAs, but you do need to have something documented on file demonstrating that you updated or revised or reviewed previous risk assessments each year for meaningful use. And again, that needs to be a current risk analysis, and then the dates on your documentation should reflect that.
All right. Second question. I qualify to use the new flexible cert rules and want to use Q2 as my reporting period using my old 2011 EHR technology. However, I haven't done my SRA yet for this year. I was most likely she was planning on doing a Q4 maybe, but now in the flexible rules, she's backing up and decided they're going to use Q2. Does that mean I can't use this earlier reporting period?
You can, due to the CMS's recent announcement, as long as you complete the SRA before you attest. And that has stayed. That was in the final rule, and that requirement still stands. You have to complete the SRA before you attest to meaningful use. However, it doesn't necessarily have to fall in the reporting period if you're using those flex rules. But again, and I'd like to just reiterate this, that's only for practices exercising the cert flex rules. So you would have to be doing so.
Okay. What are your top 3 recommendations for improving security at my clinic?
Sure. Yeah, that's a good question because there's a lot of information here. It's a lot to digest. So off the cuff, the first is to complete an SRA. If you ever suffer a breach, you're very likely to be investigated. If you're audited, in either case, whether it be a breach investigation or an audit, the Office of Civil Rights is going to ask for your risk assessment documentation, and they expect you to have one completed. It is a requirement. So make sure you complete an SRA, and you want it to be a thoughtful process. You want it to reflect what's going on in your practice. You want it to be accurate. It doesn't do good. It doesn't do you any good to do a risk assessment and kind of gloss over some of the issues or not take your time to really consider some of the threats and vulnerabilities in front of you just to have an easy process and make the risk assessment look good. You really want to make sure that it's a meaningful document because the second thing, if I had to pick 3, would be to integrate your risk assessment with an ongoing risk management program and make sure that's in place. You want to have documentation relating to regular meetings, and you can integrate security with your staff meetings. In fact, I think that's a really strong way to do it. If you're having regular staff operational meetings, designate some time for each meeting to discuss a security-related topic, and then take meeting notes and document that, and keep that documentation as part of your risk management program. And having that ongoing risk management program is a great way to demonstrate that you are taking risks seriously and that you are doing a good faith effort. And then for number 3, this could very easily be number 1, but I wanted to start with the SRA. But number 3 is employee education and basically continuous reinforcement of the importance of security. And naturally, security exists in a business setting, and you have to have balance between your operational effectiveness and efficiency and keeping patient information safe. but security is really, really important. We're protecting patients' information, and if patients' information is breached, that harms them. So the number one source of breaches being internal, oftentimes it's the result of staff who either weren't trained on the rules, weren't aware of the rules, or are just not that cognizant of security considerations on a day-to-day basis. So it really all ties back in with that ongoing risk management program. But for management to not only make sure that they're providing educational opportunities for staff and then reinforcing security considerations on a regular basis as part of normal operations, but also having continuous and ongoing education and reinforcing those points so that it's not just a one-time you sit down and watch the HIPAA video educational session. Show them that you're serious about it, and your staff will take it seriously, and that will really improve these three steps: doing the SRA, the ongoing risk management program, and education and reinforcement will really improve your security posture and reduce the risk of a breach. I should say, though, in the process of doing these three steps, you should be following HIPAA and NIST guidelines. So make sure that you're taking it all into consideration while you're doing that.
Okay. We had a question asking for a link to the slides. If you look in your chat window right now, there's a link to the PDF that's up on the MCEDA website. But all of our slides are stored in the same place there. So if you go to the mceda.org website, click on the Resources tab at the top, and then toggle down to Webinars, you'll see a listing of all our past webinars there. Next question is, are there any free SRA tools you would recommend?
Well, there are free SRA tools. The Office of the National Coordinator, in conjunction with CMS and Department of Health and Human Services, has released a security risk assessment tool that is designed for practices to conduct their own risk assessments, and that can be downloaded without a cost. There are some drawbacks to the tool, and broadly speaking, I would say that if you choose to go that path, the idea really is that a practice should be able to conduct its risk management program on its own. But especially for first-time practices doing that risk assessment, if you're using a free tool, or if you're just going by the official documentation that HIPAA, NIST, Office of Civil Rights, Department of Health and Human Services have disseminated, it's hard to frame some of that language in a meaningful context. And so that's where a lot of the value in having a consultant guide you through the process is. So there are some free tools out there. The Department of Health and Human Services has provided one. And feel free to avail yourself of any of those free tools out there. All the information in the previous slide, that's all free information that you can download and review, and that will show you how to do it. But again, you want to make sure that this is a meaningful process. It needs to be part of your operations if it's really going to work, if it's really going to help protect patient information. So while there are those no-cost or low-cost options available, if you are encountering some difficulties in either interpreting or proceeding, I do recommend enlisting the resources of a professional who deals with information security on a day-to-day basis. But yes, to answer your question, there are tools available.
Okay, next question. When you attest, do you need to upload a full copy of the SRA you do?
No, you just check the box. But a meaningful use audit is much more likely than a random HIPAA Office of Civil Rights audit, and it's important to understand the distinction between the two. Meaningful use audits happen to 10% of attesters. So if you are audited and you don't have documentation for that risk assessment, you're really at risk there. You'll definitely need to make sure you have documentation. Needs to be thorough, and it needs to be accurate. So while you don't need to upload any documentation directly to a test, if you are audited for meaningful use, which happens to 1 out of 10 people who attest, they will ask for that documentation.
And I can also say that one of the top reasons why folks fail their meaningful use audits is because they did not complete their SRA. That is that's a top reason right there.
Yeah, good point.
Last question we have so far. If anyone has any further questions, you want to get them typed in. We'll be wrapping up, I think, after this question, unless there's any more. Is Windows Vista able to download the security patch?
As far as I know, yeah. Generally speaking, software, operating systems, as long as they're relatively current, you're going to have the opportunity to get those regular security updates. Windows XP was it stopped receiving those updates because it's so old. And if Microsoft continues to provide security updates for all the products they've ever released, then that's just too much of an expense for them, despite the fact that Windows XP is a very popular operating system. So as far as I know, yeah, I haven't heard of any issues with Vista not being able to download the IE8 security patch. Good question, though. I would also recommend setting your operating systems and your browsers to automatically update to make sure that you have the most current security features, and then generally speaking, you won't have to worry about it so much.
That's good advice. All right, that is it for the questions. Let me turn it back over to Leslie for wrap-up.
Yeah. Well, thank you, everyone, for attending. As I mentioned, we will be posting, or maybe I didn't mention it, but we will be posting the video of today's presentation and the slides and the Q&A all on mceta.org under resources and webinars. For later, you can go and look at it if you ever have any questions, or email us if you have any questions. And we look forward to seeing you at the next webinar. Thank you.